Hello, my name is Dr. Amit Shah. I'm a consultant medical and hematologist oncologist based in East Midlands, and this is a presentation on a case study for MDforLives. Today I'll be talking about a diagnostic workup for lung cancer in a 56-year-old factory engineer. So we had a 55-year-old mechanical engineer at a car manufacturing factory. He was referred to the hospital cardiology department, reporting a heavy and painful cough with blood. We tested him and we confirmed intermittent hemoptysis, which is the spitting of blood that originates in the lungs or bronchial tubes. The patient had lost 4 kilograms of weight and a chest x-ray showed a left-sided lesion. The patient has had previous PTCA, which is a percutaneous transluminal coronary angioplasty, a minimally invasive procedure opening the blocked coronary arteries to improve blood flow to the heart. NSCLC was suspected, so additional workup was done to investigate further. The history, so it's important for us to work out if the patient had any previous history of primary disease, cough or hemoptysis, recurrent respiratory infections, dyspnea, chest pain and weight loss, symptoms of metastatic disease, bone pain, myalgias, headaches, visual changes, anorexia, weight loss and fatigue, tobacco exposure history, occupational exposures like asbestos or other chemical inhalations, or personal family cancer history. So it's important to work out what is their history risk, medical history risk of NSCLC. So in labs, these tests are based on ESMO guidelines for workup for diagnosis and staging of NSCLC. So you would, in general, you would do a medical history, physical examination, you would assess comorbidities and the performance score. In imaging, you would do X-ray thorax, CT thorax, PET-CT thorax, and an MRI of the brain. You can optionally do a bone scintigraphy or a contrast-enhanced CT of the brain. In labs, you would do blood cell counts, renal function tests, liver enzyme tests, and bone parameters. In cardiopulmonary function, you did FVC, FEV, DLCO, ECG test, and if indicated a CPET, you might also do ejection fraction or a CAG. Tissue procurement, you do bronchoscopy, EBUS, EUS mediastinal nodes, and then you do CT guided biopsy, and you might do mediastinoscopy as well. Patient that we tested, we did a complete blood count, renal, liver, bone parameters were assessed. We did pulmonary function tests on FVC, FEV1, and DLCO. We did cardiac assessment on ECG with echo. We did CPET, if indicated, and we did coronary angiogram for CAD, if indicated. So this is the patient's posterior view in the X-ray, which showed a mass lesion in the left lower zone. There was no pleural effusion. The cardiophrenic and costophrenic angles are maintained. There is no cardiomegaly. You can see lateral view X-ray shows a mass in the central part of the chest. That's known as the haziness, you can see here. Because of the haziness and difficulty to interpret these X-rays, further radiological imaging needed to be done with a CT scan of the thorax abdomen with iodine solution contrast. This showed a heterogeneous mass lesion in the left upper lobe and no pleural effusion. You can see more scans here. Move on. So when you look at histology, this includes bronchoscopy, endobronchial ultrasound or endoscopic ultrasound if indicated, CT guided biopsy, mediastinoscopy, if indicated, and coronary angiogram for CAD if indicated, coronary artery disease. The tests show a biopsy proven adenocarcinoma of the left upper lobe in a patient who smoked 20 cigarettes a day and cardiac history. So to do a fitness for surgery test, you would look at ERS, ESTS guidelines, which is European Respiratory Society or European Society of Thoracic Surgeons. Um, and you do two major evaluations to cite when checking for fitness for surgery. You can see the cardiac assessment first, to see if they're low risk. You do a FEV1 test. If they have FEV1 and depot, 80% indication, you do resection up to pneumonectomy. If they only have one of these, you do exercise test with a peak VO2, and then dependent on the criteria, you might do a lobectomy, a pneumonectomy. Sorry, it's not recommended if it's under 35. You might do a split function test, PPO peak test, and then do resection or resection up to pneumonectomy if it's under 75% or 20 milliliters per kilogram. You do a physiologic evaluation of the patient with lung cancer, and that will consider whether the patient can do resection or surgery. This is based on the chest diagnosis guides. So this is generally the algorithm we would go with for thoracotomy, a major anatomic resection. So if they have a positive low risk or negative cardiac evaluation, you would do a CPET, maybe a stair climb or shuttle walk. And if it's over 22 meters or over 400 meters, it's low risk. The VO2 max is 10 to 20 milliliters, it's moderate risk. And then high risk is VO2 max of under 10 milliliters. So to assess cardiovascular fitness, the following criteria are tested: preoperative ECG, audible cardiac murmur, the echocardiogram, myocardial infarction less than 6 weeks, not for lung resection. If it's come up to 6 months, then cardiology opinion. You do a coronary artery bypass graft surgery, and that should not preclude them for a lung resection. And then if they have significant lesions on coronary angiography, you do a CABG before lung resection. To assess respiratory function, the following criteria are tested: history test, like symptoms, exercise tolerance, performance score. You do a radiology assessment, so chest radiography, CT, ventilation, perfusion, and PET scan. You do an O2 oxygen saturation test, arterial blood gas test, spirometry, flow volume loops, peak expiratory flow rate test, static gas transfer diffusion coefficient, a shuttle test, a stair climb, 6-minute walk test, and a cardiopulmonary exercise test. Predicting post-op lung function, number of obstructive segments estimated by image technique and or bronchoscopy. T, the number of function segments to be resected, and PPO values, preoperative values. And the PPO FEV1, pre-FEV1, it's a proportion of lung to be resected. You do an estimation of post-op FEV1, the amount of air you can force from your lungs in 1 second, measured with spirometry test, and these are the results you would look at. You do a shuttle walk test. This underestimates exercise capacity. It's important to know it's not to be used alone. So grade of recommendation is 2++. That's a burden of proof. This is how you would determine for high risk, low risk, and low risk. You do a stair climbing test. So the ERS, ESTS recommend these parameters: height of ascent, cost effective, predicts mortality, morbidity. You do O2 drop after stair test. So that again informs you of the morbidity rate. You do 6-minute walk test. ESTS, ERS said this shouldn't be used to select patients for surgery. You do a CPET test, so cardiopulmonary exercise test, to check for VO2 peaks, pneumonectomy, the patient's high risk. There's not enough evidence of value for lobectomy. You do a cardiopulmonary exercise test, So you look at the peak O2 consumption, peak O2, the VO2 peak, which again, you can look at the rates for low risk, average risk, and high risk. You do ECOG score, so 1 is ambulatory, 5 is dead. You do multiple risk factors to find out what the patient's risk factors are: smoking, secondhand smoke, radon, substance like silica, chromium, asbestos, arsenic. Patients have diesel exhaust exposure. They have personal family history of lung cancer. They're a cancer survivor who had radiation therapy, or patients who smoke and take beta-carotene supplements. So you would assess the number of factors and then the percentage that leads to major complications. And these are the percentages that lead to major complications. So they have 3 of these risk factors, around 10% would have a major complication and a major risk of lung cancer. So if surgery is recommended, we start with a lobectomy. These are the steps of a lobectomy. Double lumen endotracheal tube, lateral decubitus positioning, axillary roll. Then you do a posterolateral thoracotomy. You do a thorough inspection of the pleural surface, a mediastinal lymph node dissection. You do inferior pulmonary ligament identification. If pleural affection is incised posteriorly to the level of the azygos vein on the right or the aortic arch on the left, that's what you're checking for. And you're checking for pleural reflection overlying the anterior mediastinum if it's incised. You would then do a pulmonary vein to the lobe of interest and see if it's circumferentially dissected using a blunt technique. You would divide it with a stapler. You do careful blunt dissection to skeletonize the artery and branches. You would divide it with a linear stapler. You would put the specimen in a bag, do a bronchial stump closure to test for leak intraoperatively. Bronchial stump can also be buttressed using a tissue flap. Induction chemotherapy with risk of poor wound healing. In patients with risk of poor wound healing, then you might do a pleura, pericardial fat. You divide it, immobilize the azygos vein or intercostal muscle, etc. Chest tubes are then placed under direct vision, and then you close the layer. So when it comes to anatomical segmentectomy, these are the recommendations. If it's stage 1A, so the tumor size is 2 to 3 centimeters with margins of resection over 1 centimeters. If it's stage 1 in patients with poor lung function, if a lung resection after prior lobectomy, wedge resection could be recommended in the following situations: stage 1A, so tumor size under 2 centimeters, or small peripheral adenocarcinoma with an air-containing image, so ground glass opacity, on high-resolution CT scans. So you're checking for these to check for anatomical segmentectomy. So if a patient needs to have be booked in the intensive care ward, these are the criteria. If a routine admission to ICU after thoracotomy is not indicated, if a high dependency unit is to be used to transfer the patient to an ICU, for example, if they have organ failure or ventilation, need for ventilation, and your ward isn't equipped to handle that. The patient has marginal CP reserves for cardiopulmonary capacity, moderate to high risk of HDU. And then low risk patient, thoracic surgery ward, not general surgery ward. You would do a cancer surgery plus LVRS then. Lung volume reduction surgery is a surgical procedure used to remove deceased emphysematous lung tissue. So the recommendation is anatomical lobectomy with or without complementary LVRS should be performed in well-selected COPD patients with lung cancer. And again, there's a level of evidence. The alternatives to surgery for high-risk patients are radiotherapy alone, medically inoperable NSCLC. You would look at a chart, which is continuous hyperfractionated accelerated radiotherapy, and that's preferred to conventional radiotherapy. You might do stereotactic radiotherapy, which is considered for high-risk surgery stage 1 NSCLC patients. Other radiotherapy options for high-risk patients include radiofrequency ablation and photodynamic therapy. So key opinion leaders in the management of NSCLC patients or candidates for surgery. These will be the MDT. You would look at oncologists, cardiologists, pulmonologists, radiologists, pathologists. Surgery should be conducted only at thoracic surgery specialist centres, and patients must be referred to high volume centres and treated by an experienced thoracic surgeon who must be doing at least 20 to 25 lung resections a year. Again, these are guidelines that you need to follow. Other factors for surgery. An MRI to the brain must be conducted before surgery, chemotherapy or radiotherapy because of the risks of neural contraindication. Use of low-dose CT. According to the National Lung Cancer Screening Trial, LDCT should be conducted in patients 55 to 74 years old who are current smokers and a smoking history of 30 plus pack years, or former smokers have quit within the preceding 15 years. So these are adverse events that you find during surgery. What if there's a tear in the pulmonary artery during lobectomy? You would use a sponge stick. You compress against the vertebral bodies and mediastinum. Assistance from a partner or senior surgeon as well. You might anesthetize, arrange for appropriate blood products, bringing a cardiopulmonary bypass circuit or cell saver to the operating room. Again, make sure you have suture materials, instruments, vascular clamps, all in the operating room. And hemostats and sealants should also be in the operating room. If it's the wide thoracotomy, you give full exposure to the area of injury. You achieve proximal and distal control of the vessel. You enter the pericardium and circle the pulmonary artery. Direct suture repair with a stapler if part of the specimen. If large tear, you patch. You use vessel loops. Use small atraumatic vascular clamps. Use vascular snare or vascular bulldogs, which should be used in nephrectomy or robot surgery if indicated. And you may consider early intraoperative pulmonary artery control for adhesions and you're anticipating a bleeding incident. So our case underwent a successful lobectomy and is in complete remission. And these are all the steps that you follow and the guidelines that you follow, and they're pretty much standard for any lobectomy, depending on age and comorbidities and previous previous cancer regimen. Anyway, thank you very much. It's a presentation for MD for Lives. Thank you very much.